I'm going to be focusing on deep brain stimulation for dystonia today. Just to tell you a little bit more about myself, I do have a personal connection to dystonia. My grandmother actually has cervical dystonia. And I also want to preface that I'm going to show you why I love my job. So the first description of neurostimulation was in the year 50, where Scribonius Largus treated patients with this cute little guy. He's actually a torpedo fish, and he gives stimulation. So he would actually put stimulation on where patients were having pain. And he noticed that it gave pain relief. So that was the first description of neurostimulation. And now, 2 millennia later, deep brain stimulation is what we use to treat movement disorders. And it is a surgical implantation of electrodes connected to pacemakers in the chest by extension wire. And these pacemakers in the chest send electrical impulses back to the brain to help treat symptoms of Parkinson's, tremor, and dystonia. These stimulation settings are, as Janet mentioned, very different for each patient. Every patient is very distinct from the next, so it can take us a little while to find the right setting. So part of the treatment of dystonia, deep brain stimulation, that makes it very interesting is that it's adjustable. We can adjust settings. It can be done bilaterally, and it's reversible. So one day when we find the cure for dystonia, we can actually just take these electrodes out. We can treat Parkinson's, tremor, dystonia, and OCD. These are the FDA Approved Indications for DBS, but today I'm only going to be speaking about dystonia. So these are what two of the electrodes look like. There are 4 contacts on each electrode, and most patients will have 2 electrodes, 1 on each side. This is a picture of what the electrodes would look like in the brain in an MRI. This is one system of the deep brain stimulation, where the lead is on the bottom and the extension wire is coiled behind the battery. And now there's a newer system where the electrode, it does have 4 places where we can send electrical impulses out, but these contacts here, the 2 in the middle, are actually segmented. So they're split into 3. So it gives us more programming capabilities and makes my life much more complicated. But it's very, very cool technology. So we're really excited about that. These are the new batteries. And this new technology is actually Bluetooth enabled. We can be sitting across the room from a patient and program them. It's upgradable technology, meaning that the program in the batteries can be upgraded by Bluetooth, and you don't need to change the battery if the technology is updated. So really exciting stuff. There is actually another system that's going to be coming out by the end of this year. Hopefully, it's awaiting FDA approval. So we'll see how much more complicated life can be for me, but it's really an exciting time in the DBS world. So the most common question that people ask me is, when is DBS therapy a success? And it's really when we choose the right patient, and these patients have had multiple medication trials. They don't have any cognitive issues, and they don't have a lot of other comorbidities, meaning like really high blood pressure, cardiac problems, other things like that. They go to an experienced surgeon, they have a neurologist and a programmer that knows what they're doing, and this coordination of care requires a team effort, and that patient has realistic expectations of what's going to happen after surgery. So these are really all important things that can help make this therapy a success. And the goal of DBS is to optimize benefit without causing side effects, and secondary goal is really to be able to reduce medication and maybe save the battery life. So when we have a patient that goes through surgery, they need to be seen by a neurologist, a neurosurgeon, neuropsychologist. They need medical clearance, an MRI to look at their brain, and then a long discussion about what to expect after surgery and realistic outcomes. So these expectations are that DBS is not a cure. Results take a while for us to find. It's not a quick fix. The DBS settings and medications need to be adjusted at the same time. It's a process, and stopping meds is not really the goal of DBS, but can happen. So in surgery, the patients are awake and off medications. There's a frame that's placed on the head to help the surgeon localize where they want to put the electrodes, and this is called a stereotactic frame. The surgeon is usually a stereotactic functional neurosurgeon that's been trained to do this. They have this MRI image and look at it on a targeting computer where they can make sure that they're putting the electrodes in the right place. There is a hole that's made in the skull once the patient's back in the operating room, and this hole is it's 13 millimeters. It's between the nickel and a dime, so not very big. Through that hole, the surgeon will push a drive, a microelectrode. It's the very thin electrode that's very sensitive. It can listen to a brain cell, one neuron at a time, so it can really hear what's happening in the brain. And as it's passing through different areas of the brain, every area has a different language. A famous surgeon in Canada said that it's like passing through Europe with your windows open, driving through Europe and hearing different languages as it passes down. And once we find the right language, we're happy where that placement is, and the macro electrode, or the electrodes that I just showed you, are placed in the brain. The electrodes are turned on in the operating room. At our center, they do a CAT scan in the operating room to make sure the electrode's in the right place. And then a week or two later, they'll have the batteries, the extension wire and the battery placed. So I didn't want to show you pictures of a surgery, but I do want to show you a video of a patient that has DYT1 dystonia. He is not typical of patients. He's got a lot of tremor, and he's had tremor for his entire life, basically, since he was in his teens. And he's in his 50s, so he's had a good 40 years of dystonia tremor. So you can see that he's got a little tilt, and he's got a lot of tremor in his hands. And he's a lawyer. He can't even write. He can't do a lot of things for himself. He needs help with everything. So this was extremely disabling for him. So we're going to be showing that it's asymmetric, the tremor in his arms. So, and he has some points where he can actually stop the tremor, which is called a null point. But he's really having a hard time. And you can see how different it is from one side to the other. And a lot of doctors would actually even say he might have essential tremor. So it's easy to be misdiagnosed when you have a tremor like that. So he had seen Dr. Bressman many years before, and he did not come back for treatment for, I think, 30 years. Because he was very disgruntled by the medications and side effects. And you can see, even when he's standing, he's got tremor of his legs, his trunk. When he lies down, the tremor is really terrible. He looks great when he's walking, but at rest, he's having a lot of trouble, and trying to do things like writing is very, very difficult. He's got a bad writer's cramp here.
I think it's interesting that he lived with it for 40 years, basically.
Absolutely.
And, functioned.
Mm-hmm.
But at some point, when he learned more and more about DBS, and he felt he was just getting older and it was getting more difficult for him,
mm-hmm.
he made this decision to just go and jump in and do it.
Right.
And he showed up in the office. It was amazing.
So you can just see how terrible his handwriting is. You're right, I don't know how he did it for all those years. So he decided to have, this is him trying to write a spiral. Very difficult for him. So he decides to have deep brain stimulation surgery, and as Janet mentioned earlier, it takes a while for dystonia to respond to DBS, but here his legs are still, his arms still have a little tremor, his head has a little tremor, but he's showing some improvement. And this is 6 months after surgery. He still has a writer's cramp, but he can hold the pen down and write on the paper. And he's trying to write "Today is a sunny day." Oh no, he's writing the alphabet. So, and then 18 months later, he has no tremor at all. And still, to this day, he's about 5 years out, and he looks even better. So I personally feel that DBS gets better as time goes on, and like the patient's symptoms get better over time, and it continues to improve. So he's a happy guy. I only see him once a year. And so we have a paper that describes 10-year experience with DBS for dystonia, and as you can see, the BFM-DRS, it's the Burke-von-Marsden Dystonia Rating Scale, is what we use. The higher the number, the more disabled patients are. And before surgery, you can see a lot of very high scores on the BFM-DRS, and over time, and this is 96 months later, very small numbers on the BFM-DRS. So it shows improvement and continues to show improvement after. I have some patients that are 16 years out of surgery. And they look amazing, so I'm happy to be a part of that. So this patient has cervical dystonia, and this is before she had surgery. You can see it's really all in her neck. She's got rotation, and her head is pulling down, and she is unable to look at me. So she's speaking to me, but if she tries to turn, she has a lot of pain. Her right shoulder is up a little bit. She's got a little tremor when she tries to turn. This is her range of motion. She has very little range of motion in her neck. So she is trying to put her head back. She can't do it. And this is her about 1 year later. So it takes us time to find the right setting for her, but it can be extremely rewarding for me, and also very helpful for her. So I also see once a year, just to check her batteries. And so you can see she has full range of motion. And she can drive, and she can do whatever she wants to do. So then the next patient I'm going to show, he has a different kind of dystonia called DYT6. And this is before surgery. And you can see he's just in constant motion. Even with his eyes closed, he's in constant motion. His back is pulling backwards, his shoulder wants to come up. He really has involuntary abnormal movements that he has no control over. You can't hear his voice, but he's got a little bit of spasmodic dysphonia in his speech. So he did not know he had DYT6 before he had surgery. He was tested, and the results came back afterwards. And classically, in the literature, DYT6 does not really respond well to DBS, so we were a little bit worried about him. But his symptoms were so bad, and Dr. Lubar is his physician, and she had tried everything for him as far as medication is concerned, and so she really wanted to help him, and DBS was the next thing for him to try. But you can really see that he's having a hard time. He has a lot of tremor. It's very asymmetric. His back is constantly in spasm, and he does have a lot of pain. It's very difficult for him to do things with his hands, and walking is very difficult. So I'm just gonna try to fast forward a little bit here. So this is his walk. So when he's walking down the hallway, he's moving back and forth. His back is constantly in motion. He has a lot of back pain because of this. So this is his handwriting at that point. He really has a lot of writer's cramp. It's very difficult for him to hold a pen. And this is him a year later. He has no more tremor. He has a lot better control of his back. He can really control his arms. And I'm going to just, fast forward a little bit. He has no more abnormal movements of his arms. And I'm going to fast forward to his walking. Whoops. Okay. So much better.
Okay, come on back in.
And so when he...
Okay, so today...
I didn't show his writing before, but this is his writing 1 year later. He went back to school. He went back to college courses, and he's really also very happy. So we were happy for him as well. But one more type of dystonia. So this is a patient that we think has myoclonus dystonia. He's got just his whole body is in constant motion. He came to us and he was just not happy at all. We tried lots of things. This video is actually from Beth Israel North, which no longer exists. So you can see a lot of retrocollis, a lot of just constant movement. Even when he's walking, he's in constant motion. And he had deep brain stimulation eventually, after we tried a whole bunch of medications for him. And this is 9 months after he had surgery. And he still has a lot of movement in his face, a lot of pulling in his neck, a lot of movements in his trunk and his arms still 9 months later. And we were just scratching our heads a little bit. And there was one article from a Japanese group that mentioned low-frequency stimulation, and we wanted to just try it. So I moved down by 5s in his frequency. We had been using 130, and once I got to 70, you'll see in the next segment, we stopped at 70, and his movement stopped right in front of our faces. And we were so happy, and so was he. He's like in shock right now. But he had so much more control over his movements, they basically stopped. And when we looked back in his operating room notes from the neurophysiologist, his GPI frequency firing rate was about 75, so we just went around where his GPI firing rate was, and it made his dystonia so much better. So he was the reason why we started using low-frequency stimulation, and that's what I use now in programming for dystonia. it really has given us some amazing results. And it seems to work faster for patients and quicker and saves batteries. So how does DBS work? We're not really sure. I'll be the first person to say that. We don't know how it works. And this is my favorite Far Side cartoon, but we're just kind of poking around in the brain and trying to find the right settings. But we try systematically to find the right setting for patients, and it takes us a while, but we'll find it eventually. There are non-pharmacologic treatments for dystonia as well that we use after surgery. We use PT, OT, and speech therapy can be very helpful. And just to summarize, DBS can be very, very effective and life-changing for the right patient. We need to work with the right team, surgeon, neurologist, and a programmer. DBS is not a cure, it's not a quick fix. This is a process. Medications can be decreased, but not always stopped. This is the team that we use here. We have movement disorder specialists, multiple. We have a neurosurgeon at our center, it's Dr. Coppell. We work with a psychiatrist, Dr. Groves, our genetic counselors, Debbie Raymond. Neuropsych is Dr. Palmisi. We have multiple PTs, OTs, and speech therapists. We send out to, I saw some Fox Rehab people send to you a lot. We have a social worker and researchers and movement therapists that can also help dystonia patients. So thank you for your attention.